Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. A staging of any cancer is done to segregate patients into risk categories that define prognosis and guide treatment recommendations for patients with similar prognosis. Clinical breast cancer staging is performed through physical examination and imaging studies before treatment. Pathological staging is done through pathological examination of the resected tumor and lymph nodes postoperatively. Breast cancer staging involves the TNM system that groups patients into 4 stages based on the size of the primary tumor, T, a status of the regional lymph nodes, N, and presence or absence of distant metastasis, M, ranging from a stage 0 to a stage 4. Higher stage indicates more cancer spread. The most widely used system is that of American Joint Committee on Cancer Staging System. The latest AJCC protocol version 9 was released in January 2025 and is now available electronically. It provides a fundamental framework for clinicians in treatment decision making, researchers in the design of future trials, and cancer registries for epidemiological studies. A more pragmatic approach in use is to classify patients according to the treatment that they require. This approach groups patients as very low risk primary breast cancer, low risk primary breast cancer, high risk primary breast cancer, locally advanced cancer, and metastatic cancer. The prognosis of breast cancer depends on the tumor size, TNM grade, and lymph node status. However, there are cases where large tumors will remain confined to the breast for many years or even decades, whereas some very small tumors are incurable at diagnosis. In other words, the prognosis of a cancer depends not on its chronological age, but on its invasiveness and metastatic spread. Aggressiveness of breast tumor depends on a host of prognostic factors, including the histological grade of the tumor, hormone receptor status, Ki67 expression, growth factor analysis, and oncogene or oncogene product measurements. A high Ki67 expression indicates a more aggressive tumor with a high risk of recurrence. The Nottingham Prognostic Index is a tool used to predict survival and response to adjuvant chemotherapy in breast cancer patients, particularly those with estrogen receptor positive, HER2 negative, and node negative breast cancer. It considers tumor size, histological grade, and nodal burden to calculate a score that helps stratify patients into prognostic groups. Patients with moderate or poor prognosis are often considered for adjuvant chemotherapy. There are also computer-aided programs such as Predict Breast that help patients and surgeons see how different treatments for early invasive breast cancer might improve survival rates after surgery. Surgery is considered the primary treatment for early stage breast cancer. Many patients are cured with surgery alone. The basic goal of breast cancer treatment should be to reduce the chance of local recurrence and the risk of metastatic spread. This involves complete excision of the primary tumor with negative leftover margins, to reduce the risk of local recurrence and pathological staging of the tumor and axillary nodes to provide necessary prognostic information. Treatment of early breast cancer is surgery with or without radiotherapy. Chemotherapy or hormone therapy is added if there is lymph node involvement, indicating a high likelihood of metastatic relapse. The treatment of locally advanced or metastatic disease is usually palliative, involving chemotherapy or hormone therapy. Here, surgery has a much smaller role. SIGN 84 is a national clinical guideline for the management of breast cancer in women, developed by the Scottish Intercollegiate Guidelines Network. It provides recommendations for diagnosis, treatment, and follow-up of breast cancer in women. SIGN 84 addresses issues in breast cancer like the role of sentinel node biopsy in axillary node staging, the place of aromatase inhibitors in the adjuvant setting in postmenopausal women with estrogen receptor positive breast cancer, and the role of Herceptin in the adjuvant setting in women with HER2 positive breast cancer. Surgery plays a central role in the management of breast cancer, but there has been a gradual shift towards more conservative techniques such as local excision followed by radiotherapy instead of mastectomy. However, both approaches have pros and cons. Indications of mastectomy are large tumors, central tumors beneath or involving the nipple, multifocal disease, local recurrence, or patient preference. Breast cancer is a heterogeneous disease. Current treatments are guided by molecular properties of the tumor, as well as its size and location. Before initiating local therapy, the surgeon should determine the clinical stage, histologic characteristics, and appropriate biomarker levels. A skin-sparing mastectomy removes all breast tissue, the nipple-areola complex, and any biopsy scars. Recurrence rate ranges from 6% to 8% when a skin-sparing mastectomy is used for patients with TIS to T3 cancers. This is comparable to the long-term recurrence rates reported with the standard mastectomy. A total or simple mastectomy removes only the breast, including the nipple-areola complex and skin, with no dissection of the axilla, except for the region of axillary tail, where level 1 anterior group nodes exist, located below and lateral to the lower edge of the pectoralis minor muscle. Nipple-areolar sparing mastectomy is being used over the last decade as a risk-reducing mastectomy in high-risk women. Criteria for selecting patients for this approach are a smaller breast size, tumor located more than 2 to 3 cm from the border of the areola, minimal ptosis, no prior breast surgeries, and peri-areolar incisions. Body mass index less than 40 kg per square meter, no active tobacco use, no prior breast irradiation, and no evidence of collagen vascular disease. The Patey modified radical mastectomy is a more commonly performed operation to treat breast cancer. It removes all breast tissue, the nipple-areola complex, skin, and the level 1, 2, and 3 axillary lymph nodes. The pectoralis minor muscle is either divided or retracted to gain access to the level 3 nodes in the upper two-thirds of the axilla. The excised mass is composed of the whole breast, a large portion of skin, including the nipple and areola, plus all the fat, fascia, and lymph nodes of the axilla. The axillary vein and the thoracodorsal trunk supplying the serratus anterior and latissimus dorsi muscles should be preserved. The intercostal brachial nerves are usually divided. The wound is closed over a wide bore suction tube. Early mobilization of the arm and physiotherapy are helpful to regain normal activity of the arm. The Helsted operation or radical mastectomy is a surgical procedure that involves removing the entire breast, all axillary lymph nodes, and the pectoralis major and minor muscles. Now rarely used as it causes excessive morbidity with no survival benefit. Radical mastectomy was abandoned in favor of more conservative surgical approaches such as systemic chemotherapy and hormone therapy in combination with adjuvant radiation therapy. Breast conserving surgery or BCT involves resection of the primary breast cancer plus a margin of normal appearing breast tissue, adjuvant radiation therapy, and assessment of regional lymph node status. Resection of the primary breast tumor with preservation of the breast is alternatively also called segmental mastectomy, segmentectomy, lumpectomy, partial mastectomy, wide local excision, and tylectomy. In quadrantectomy, the entire segment of the breast that contains the tumor is removed. All of these operations are usually combined with axillary surgery, usually via a separate incision in the axilla. Options for axillary surgery include sentinel node biopsy, sampling, removal of level 2 nodes, that is, the nodes behind and lateral to the pectoralis minor, or a full axillary dissection, that is, level 3 node clearance. The surgical defect created is closed in cosmetic fashion with the advancement flap closure or other oncoplastic surgical techniques. Controversy exists regarding the margin of clearance. Some units favor a 1 cm margin and others 1 mm, but many still regard 1 mm as a safer margin. In cases with stage 1 or 2 female breast cancer, breast conserving therapy is preferable to total mastectomy because BCT produces survival rates equivalent to those after total mastectomy while preserving the breast. Breast preservation retains breast shape and skin, as well as sensation, and provides an overall psychological satisfaction. Currently, breast conservation surgery is the treatment of choice for women with stage 0, 1 or 2 invasive breast cancer. Ductal carcinoma in situ requires only resection of the primary tumor plus adjuvant radiation therapy without regional lymph node excision and assessment. Local recurrence rates are somewhat higher following conservative surgery, even if combined with radiotherapy, but the long-term survival benefits remain unaffected. Local excision alone without radiotherapy is associated with an unacceptably high local recurrence rate. Local recurrence is more common in younger women, in those with high-grade tumors, and with involved resection margins. If margins are involved, a further local excision or a mastectomy should be performed before radiotherapy. The presence of metastatic disease in the axillary lymph nodes is the best single marker for prognosis. The axillary clearance is done to stage the cancer and to treat the axilla. Treatment of the axilla does not affect long-term survival because the axillary nodes are not a reservoir of disease but act as a marker for metastatic potential. Both premenopausal as well as postmenopausal patients require axillary staging. Axillary surgery should not be combined with radiotherapy to the axilla because of added morbidity. The internal mammary lymph nodes removal is unnecessary. The first lymph node to which cancer cells are likely to spread from a primary malignant tumor is known as the sentinel lymph node. Sentinel lymph node biopsy helps determine if cancer has spread beyond the breast and into the lymph nodes, which is crucial for accurate staging and treatment planning. If the sentinel nodes are negative, that is, if they have no cancer cells, axillary surgery may be avoided, otherwise it can cause complications like lymphedema. Sentinel lymph node dissection is mainly used to assess the axillary lymph nodes in women with early stage breast cancer, T1, T2, and 0, with small tumors of less than 2 cm size, in whom the lymph nodes are not palpable by physical examination or identifiable by imaging studies. Any suspicious nodes are biopsied by either fine needle aspiration cytology or core needle biopsy. The sentinel node is localized preoperatively by the injection of patent blue dye such as isosulfan blue or methylene blue and radioisotope labeled albumin in the breast. The recommended site for injection is in the subdermal plexus around the nipple. The marker in the node is detected visually and with a handheld gamma camera. Preoperative nodal disease diagnosis is achieved using frozen section analysis, touch imprint cytology, or by homogenizing the node and detection of a gene such as cytokeratin 19 or mammoglobin. Mammoglobin and cytokeratin 19 are used as a biomarker for breast cancer, particularly in detecting primary or metastatic breast cancer, monitoring lymph nodes, and predicting disease outcome. The Sentinel node biopsy has transformed the surgical management of early breast cancer, and it is now the standard of care. Two absolute contraindications for Sentinel node biopsy are patients with inflammatory breast disease and patients with clinically or biopsy proven positive axillary nodes. These patients would require axillary lymph node dissection. The Sentinel lymph node biopsy is highly accurate, but there is a small risk of false negative results, meaning that cancer cells might be present in other lymph nodes that are not identified as Sentinel nodes. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.